right, I will now introduce our next speaker, Dr. Sheila Stewart. Dr. Stewart is the Gertie T. Corey Professor of Cell Biology and Physiology in the Department of Cell Biology and Physiology and Medicine at WashU in St. Louis. She's also the Vice Chair of Cell Biology and Physiology and the Associate Director for Basic Science at the Cancer Center there, the Siteman Cancer Center. She received her PhD in microbiology and immunology from UCLA and then did a postdoc fellowship in cancer biology at Bob Weinberg's lab at MIT. In her own lab, Dr. Stewart has really done fantastic work looking at telomere dynamics and trying to understand age-related changes in the tumor microenvironment and how that impacts tumorigenesis. And I think we're all appreciating so much more the effect of this on cancer progression. So Dr. Stewart's presentation is entitled Therapy-Induced Senescence, Friend or Foe?
So I want to thank the organizers and Dr. Walm for this invitation and reiterate what Ruben said. Thanks for getting up this morning. So today I'm really going to focus on why getting old stinks, but we're going to focus this only in the answer of questions. The rest of it we'll have to talk about martinis. So these are my disclosures. And basically this graph right here recapitulates what we think about all the time. Why is it we see such a drastic increase in tumorigenesis in the later decades of life? And I'll point out, when you look at this graph, it doesn't matter which cancer we're talking about, and it doesn't matter if you're looking at males or females. Make it to that 5th or 6th decade of life, and we see a significant increase in tumorigenesis. And when you see something like this, you really do have to take a step back and ask the question, why? What is it that's driving this rapid increase? I think the answer is complicated. This is a complicated set of diseases. Certainly, I think many people, the previous speaker certainly alluded to the importance of mutations, and I think most of us agree that adult cancers are primarily the result of multiple mutations. And so in the face of robust DNA repair, it's just going to take time, not just to get mutations, but the right combination to take that normal cell down that road to transformation. And so I ask all of you in the audience, is that enough? Is this the single important driver that can explain that rapid increase in tumorigenesis that we see in those later decades of life? Of course, I wouldn't be setting you up if I didn't think there might be other things we should be considering. And we've really focused on the potential role of senescent cells. These cells also are something that we see accumulate as a function of age across different tissues. And of course, one of the reasons that we got interested in these quite some time ago is that when you look at the phenotype of senescent fibroblasts, they recapitulate every phenotype that's been ascribed to a cancer-associated fibroblast, in that they're able to influence every step in the transformation process. So certainly they can do, in the models that we've all set up across different systems, the same things these cancer-associated fibroblasts do. But I think the data that really argues that these cells could be critical comes from a very lovely paper from Darren Baker's group several years ago. I'm not going to go into the genetics of how Darren created this mouse, but all you need to know for today's talk is add a dimerization drug called AP, and you basically kill P16 positive senescent cells. And I hope what you can appreciate if you look at the graphs from his paper is it doesn't matter if you're a male, it doesn't matter if you're a female, it doesn't matter if you're on a mixed background, and it doesn't matter if you're a pure background. Simply by eliminating senescent cells, you significantly delay the onset of tumorigenesis. Now, how this happens is complicated. I'm not going to go into the possibilities of pre-neoplastic cells versus senescent fibroblasts, but there is quite a bit of data to say that the major driver of this, at least in the mammary gland, is probably through the elimination of senescent fibroblasts. So what do these things do? They basically secrete everything yummy you can imagine if you're a tumor wannabe. They dump out growth factors, they dump out factors that can modulate the ECM, and they also dump out inflammatory cytokines and chemokines. Second largest risk factor for the development of cancer after the bad luck of getting old, chronic inflammation. And these cells, both CAFs and senescent fibroblasts, drive the expression of many of these pro-tumorigenic and inflammatory cytokines. So several years ago, Elise Alsbach, when she was a graduate student in the lab, really wanted to understand what the molecular mechanisms were that were driving the secretion of many of these pro-tumorigenic factors. And what Elise was able to show, using both genetic models as well as pharmacologic approaches, is that both if we looked at senescent fibroblasts or if we looked at cancer-associated fibroblasts, by limiting the P38MK2 pathway, she was able to actually limit the expression of many of these factors and limit the ability of both CAFs and senescent fibroblasts to increase tumorigenesis, and specifically was able to show, again in vitro as well as in vivo settings, that a pharmacologic inhibitor of p38 could similarly limit the ability of these cells to grow in a primary tumor. When Bhavna Murali joined the lab, she was interested in asking the question whether this was limited to the primary setting or whether we could see something similar in the metastatic setting. Here I'm just showing one IHC without the quantitation, which is in her paper, but basically what she was able to show is when she went and looked at breast cancer metastasis to the bone, she could show evidence that the p38 and MK2 pathway were certainly active, sometimes in tumor cells, but often, if not always, active within the stromal compartment within those metastatic lesions. And so she wanted to ask if it mattered in any way. And so, I just went backwards, I apologize. And so we've actually mostly focused on using an intracardiac injection model, and I'd just like to point that out because when it comes to the mouse, unfortunately, we do not have a robust spontaneous model that goes to the bone. And so the nice thing about the intracardiac injection model is it allows us to distribute the tumor cells widely across both the visceral organs as well as the bones. I'm not going to show you data today, but we've shown similar results with our inhibitors that I'm going to show you with this model when we use resection models. It's just much less efficient, so we focus primarily on the intracardiac injection model. And so what Bhavna did was to create basically a preclinical model. For interest of time, I'm just going to show you data from one cell line today, but she's repeated this with 5 different lines, both luminal A, luminal B, as well as her 2 new positive lines, and she sees exactly the same thing. And so what Bhavna did was to introduce the cells and randomize her animals either onto standard of care, which is paclitaxel, still used in the metastatic setting today, or on an inhibitor against the p38 kinase. And I hope what you can appreciate is if we look on the right, we're looking at bone metastasis, and we also got the same event when we looked in the visceral organs, which is shown on the left, that paclitaxel, or PTX, as expected, was effective at limiting metastatic outgrowth of this tumor line. And we saw exactly the same thing with the p38 inhibitor as a single agent. So we were actually pretty excited about this. But I set you guys up saying that we were inhibiting the stromal compartment. And here we're using a drug that hits the animals at large. And so Bhavna did 2 experiments to try to approach this. On the one hand, on the left, this is an in vitro assay showing that these cells in the blue bar are in fact sensitive to paclitaxel, could care less if we put the p38 inhibitor on them. I think more convincingly, though, is the data off to the right there. This is basically using an shRNA to limit p38 expression in the tumor cells themselves. And when those are introduced into the animals, and that's those orange or peach squares, you can see that they grow just as well as the controls, which are the blue circles. And I think this data argues that the primary target of our drug is, in fact, the stromal compartment. Now, when Elise was in the lab, what she was able to actually show is that it's p38's ability to activate the MK2 downstream kinase that leads to mRNA stabilization of these senescence-associated secretory phenotype factors, or the SASP. And so we wanted to move more proximal to our actual target. And so we repeated the exact same experiment, and we had the good fortune of a local company in St. Louis that had been developing novel inhibitors against the MK2 inhibitor. And I hope what you can appreciate is using the same approach that we used with the p38I inhibitor. Again, those triangles there are single agent MK2 inhibitor are able to limit tumor growth to the same extent as the paclitaxel is able to. Now, one of the great things about having grad students is they are excited and they notice lots of things. And one of the things Bhavna came and told me, she says, we only get a little bit of survival advantage, but the mice are a lot happier. And of course, me being the person in the front office is like, define happier. What makes a happier mouse? She says, well, they're running around a lot more. And so we started to think about this in the context of what happens in the clinic. And certainly when patients have metastatic bone lesions, they can have significant pain and also pathologic fractures. And so we wanted to ask whether or not the bones were actually being involved here. Now, of course, in the clinic, we have denosumab, which is able to reduce, and zoledronic acid, reduce metastatic problems in the bone by about 1/3. And I'll remind you the way that this works, particularly when we're talking about zoledronic acid, is it covalently links to the bone, and that's able to kill the osteoclasts that are responsible for thinning out those bones. Unfortunately, except in the postmenopausal setting in patients, this doesn't slow down tumor growth in any decipherable way. And we knew that the p38 MK2 pathway was actually very, very important both for osteoclast differentiation and their ability to resorb bone. And so we asked the question, are we in fact protecting the bones of these mice? Could that explain why they are quote unquote happier? So what I'm showing you here is trabecular BVTV for today's talk. Just think about it as bone density. And I'm showing you here what we would have on this particular strain for an animal without tumors. And the reason I'm showing you that is I don't like fake data, and I'd have to show you the vehicle floating somewhere down here. So animals that are treated with vehicle have such big holes in their bone, we really can't get an accurate read of what their bone density is. So it's probably floating somewhere down here. And what we were excited to see is, again, paclitaxel, that's the PTX. We do see a significant loss in bone density, but we do see some protection, as I will remind you, in tumor progression. But what was exciting is the P38 inhibitor, as well as the MK2 inhibitor, as single agents, were as effective as zoledronic acid at protecting those bones from loss in the face of ongoing tumorigenesis. And what's exciting is, unlike the zoledronic acid, which I mentioned to you in patients, is unable to protect or slow down tumor growth, the MK2 and P38 inhibitors are, in fact, able to slow down tumor growth to the same extent as standard of care, paclitaxel, and to protect the bones. And this has actually led to the design of a clinical trial with my collaborator, Cynthia Ma, who I think is hiding in the back there, in which we're going to use the MK2 inhibitor in the metastatic breast cancer patient setting. So I like to say we got a 2-for-1, if you will. On the one hand, the P38 inhibitor is very effective at limiting the stromal support of ongoing tumor growth in the bone as well as the visceral organs, but it also limits the ability of the osteoclast to actually resorb bone and results in reduced density. Now, this data actually got us thinking about what's going on, not just in the primary setting, but also, the metastatic setting, but also the primary setting, where actually patients who are exposed to chemotherapy also lose bone. And this has actually been thought to be due to the loss of estrogen, which plays a very, very important role in bone homeostasis. And I think that's very well shown here when you look at the average bone loss of an individual going through menopause, where you can lose upwards of 2% of your bone in the first year. Why is that? Truth be told, estrogen talks to every major cell in the bone that's responsible for bone homeostasis: osteocytes, osteoblasts, and osteoclasts. And so the thought has been that when you're exposed to chemotherapy, you lose estrogen, and you're really screwing up the ability of these cells to communicate and maintain bone homeostasis. I think this is underscored when you look at patients that are on aromatase inhibitors who lose upwards of 3% of their bone per year. So certainly estrogen is an important component of bone homeostasis. Our issue when we were thinking about this from the lab, though, is when you look at patients that are on chemotherapy, they're losing upwards of 8% of their bone per year. And so the question is, where is this extra bone loss coming from? And so we knew, turns out in the lab at least, the best way to induce senescence, this senescence-associated circulatory phenotype, and all of its downstream consequences, is chemotherapy. Works every time. It's the first thing we give a grad student to do when they enter the lab. This is an SA beta-gal assay. It's not the best assay, but it is one way in which we can look for a senescence. And certainly when we treat our animals, now this is in a tumor-free setting, with doxorubicin, we see increases in SA beta-gal. So we wanted to use that mouse I mentioned earlier, Darren Baker's mouse, that allows us to specifically kill senescent cells in an inducible manner, to ask, is it possible that the induction of senescence post-chemotherapy is indeed contributing to the bone loss we see in a primary setting? And so Ganesh Root in the lab was able to use this mouse. And basically what he could show is, if you look at bone density again, shown on this graph, we lose bone when we expose animals to doxorubicin. Those are the squares there. But when we actually put these animals on this AP dimerizer, we specifically kill senescent P16 positive cells. Those are the diamonds in the last column there. We actually recover the bone loss, arguing that it is in fact senescent cells, and we've gone out now to show that it's bone resident senescent cells that are driving the bone loss that we see in this model. So given the importance of the P38 and the MK2 inhibitor, we actually went back and asked the question, could we again use those inhibitors, limit the secreted factors, and in this case protect the bones? So certainly we could show that when we expose animals again to doxorubicin, there is activation of this pathway, giving us good reason to use it. And basically what we could show is, again, that bone loss that we see when animals are exposed to doxorubicin is recovered both when we use the P38I as well as the MK2I, the inhibitors to these two drugs. And so one of the things that we're excited about is, if we see success in the metastatic setting in this trial that we're planning with Cynthia Ma, is whether we can't move this backwards and start thinking about how not just to help our patients live longer, but how might we make them live better by protecting their bones with these approaches. So our goal, though, is to help our patients live better and longer. And so how do we actually take the information that we've learned about the tumor microenvironment, particularly in the bone, and push these curves out to the right? How do we actually extend the survival of our animals? Given the shortness of the talk, I don't have time to show you the data, but we've done bone marrow transplants using floxed alleles of the P38 gene and have been able to show that the target of our P38 inhibitor is, in fact, CD45 positive cells. And so we wanted to ask the question, what is our inhibitor doing to these cells, and how is it limiting tumorigenesis? And can we use that information now to drive this curve out to the right? So how do you do that when you're interested in the bone? How do you do that when you're interested in CD45 cells that basically float in an ocean of immunity in the bone marrow itself? If the tumor immunologists have taught us one important lesson, it is what is actually happening in the metastatic lesion and the tumor lesion is really critical to the response to immunotherapy. And so we decided to take advantage of an elegant system that was designed by Ilaria Malachi at the Crick a few years ago, in which you transduce your tumor cells with a soluble M-cherry. This allows M-cherry to passively move through the membranes and basically label proximal cells. Ilaria's group has done a number of controls, as have we, to basically show that this doesn't really go very much farther than about 100 microns. And so what we wanted to ask is, could we use this cell, isolate tumor cells as well as the immune cells and other stromal cells inside that metastatic lesion, and ask how our therapy is changing them? I'm just going to focus on the CD45 positive cells for today. We saw many changes both in the CD45 negative as well as the positive, but the most profound change that we saw in the cherry positive, so these are immune cells physically inside those tumor lesions, really was in the macrophage population, and that's those blue cells that I've circled for you. There are a lot of changes. I'm highlighting just a few that we've also gone back to confirm by IHC. And what was interesting is the types of changes that we were seeing was increases in what would be gamma interferon responses. These are things we think of as an active immune response. Significant increases in MHC class II, as well as STAT signaling. And so the question was, given this change in the macrophages, were the macrophages the important CD45 cells that were limiting tumor growth within the metastatic setting? So to do this experiment, a very talented postdoc, Douglas Fauget, decided to use cladronate and CSF depletion to ask whether or not, if we lose the macrophages, what happens to the ability of the P38 inhibitor to limit tumor growth. And I think a picture is worth 1,000 words showing there, but it's quantitated for you there in the middle. I hope what you can appreciate is when he eliminates macrophages from the system, the P38 inhibitor's ability to limit tumor growth is completely eliminated. So macrophages really are the pointy end of the stick. They're very, very important for P38 inhibitors' ability to limit tumor growth. Again, in the interest of time, I'm going to sum up a whole lot of data, probably would make Douglas cringe given how many years it took him to do this. But what he was able to go on to show is, in fact, as I've shown you already, P38 inhibitor drives up increases in MHC class II in the macrophages. This is limiting tumor growth. He's gone on to show that NK cells and CD8 cells are completely irrelevant. They are not active in this model at all. In fact, CD4s are the kingpins here, and it's their ability to specifically secrete gamma interferon that's driving that increase in MHC class II and the ability of tumor cells to limit tumor growth, again, in the metastatic setting. But I started this off by saying what we wanted to do is to push this curve to the right. How do we use that information and other information that we have to do just that? So we went back and started looking at what else was going on in those CD45 positive cells. And what was interesting is, many of the things we think of as an active immune response were there, co-expression of CD80, 86, and other things. But what was interesting is there was no OX40 ligand. And this really caught our attention because through a collaboration with Eric Knudsen, we were able to show that looking at a human breast cancer set, so these are actually metastatic lesions from human patients, they too were deficient in that OX40 ligand. And so what is OX40? OX40 is the gas, if you want to. We think a lot about the checkpoints and the brakes when we think of PD-1 and CTLA-4. For simplicity for today, OX40 is the gas. And so when we looked And we said, okay, if we're missing it, what happens if we give it back? What if we put gas back in the car? Can we push that curve to the right? And what we were able to show, remember I told you CD4s are the sticky end of this, or the pointy end of the stick. We could show that when we used an agonist against OX40, an anti-OX40, we significantly increased activation of our CD4 T cells. And so when we combine these now in our animals, I hope what you can appreciate showing you tumor growth on the graph is that both the anti-OX40 ligand as a single agent and P38I as a single agent are equally effective at limiting tumor growth. And we see even a further increase when we put these two together. And so now we are starting to push that curve out to the right. In green there is the combination. But I told you, OX40 is important for T cells. That includes CD8 T cells. And certainly when we went back and looked at our CD8 T cells, we found that they too were showing increases in activation markers, again on their surface. But we knew they weren't important. We don't have a CD8 antigen in the system. So we introduced an experimental antigen and asked the question, what happens if we actually have an experimental antigen? So we used OVA for this approach. And I hope what you can appreciate is we've basically cured the disease in these animals. That green line on the top are our animals that now have an experimental antigen against CD8 and the double combination of the P38 and the OX40 agonist. Now, of course, the real litmus for whether you've cured and actually pushed immune memory is whether or not you have recall. So we took the animals that were on the green line, these are the ones that were cured, and we re-challenged them with the same tumors. Of course, when we take naive animals and challenge them, tumors grow quite robustly in them. But I hope what you can appreciate is all of the animals that had the double treatment are completely resistant to a challenge with the tumors. And so we have, in fact, pushed that curve to the right. And so basically, what does this mean in the real world? We went back to look at TCGA data from patients, and what we thought was really interesting is when we looked across different subgroups, if you looked at people that looked like they were on our inhibitor, so had low expression of P38-dependent factors, those are the red lines, they do much better than the others. But I think what was even more impressive is when we then layer that information on top of the mutational burden of these patients, using high mutational burden as a surrogate for potential CD8 responses. I hope what you can appreciate in the red, these are high mutational burden, presumably they're going to have CD8 responses. They certainly have evidence of more infiltration of CD8 and CD4s, and they look like they're our inhibitor, that's red. They do very, very well. Whereas those that look like they are not our inhibitor, they look like our vehicle mice, they're blue, they do very poorly. And what we think is important about this is it suggests that the patients that would benefit most from this approach are in fact the blue patients, not the reds. And with that, I'd like to finish with the most important slide, and that is the people that did the work. I've tried to mention their names as I go along, and also our amazing collaborators and funders. And with that, I'd love to take any questions if you have them. Thank you.
Thank you very much, Dr. Stewart. There are mics now in the back, so please go up to the mics, introduce yourself, and ask your questions. We don't have any questions online yet, but I'll keep an eye on that. I might start with a question. Very interesting talk. I'm thinking about the effect of doxorubicin on the bone and the fact that blocking P38 could help relieve some of that. But it makes me think also about other toxicities that come with chemotherapy and to what extent you think that senescent cells might actually be contributing to this.
Yeah, so it's a great question. We've only delved more recently into peripheral neuropathy. So we're not seeing any obvious effects with the P38 inhibitors, but if we use senolytics, and they have their ugly warts, we actually can completely reverse the peripheral neuropathy that we see with paclitaxel at least. And so we do actually think that these cells are contributing more broadly. What I don't know is, are they 7 steps removed or are they direct? In the context of the bone, though, we do now know that is a bone-resident cell specifically driving loss. So I think it's going to be a mixed bag.
Any other questions? Yes, there's one in the back. Thanks.
Hi, Sheila. Thank you for a great talk. It's Shom Goel here from Peter Mac in Melbourne, Australia. I have a question about the P38 kinase and particularly its role in tumour cells. I know that it didn't seem to do much to knock down P38 in tumour cells, but I'm wondering what happens if you first render those tumour cells senescent. Does a P38 inhibitor then impact their SASP or their survival in any way?
Yeah, so if I understood you right, the question is what happens if we have senescent tumor cells in the context of the P38 inhibitor?
Correct.
Yeah, so we haven't, at least at the drug concentrations that we've been using, we don't see robust induction of senescence. What's interesting about senescence, though, is different cells have different SASP. So whether or not the effect would happen in the tumor cells because of senescence, I don't know. What I can tell you is Keon Lim has some beautiful data that was recently published showing that if you combine inhibition of the pathway with FOLFIRINOX in the pancreatic setting, he has a significant reduction in tumor growth, and that's tumor intrinsic. So I do think you're going to see both. I think it depends on the model, but at least with the 5 models we've tried in the breast setting, in the bone, the tumor cells don't seem to care about it.
Thank you.
Ruben Harris, UT Health San Antonio. So this OX40 molecule, do you see it as something that will be more of a monoclonal antibody therapy, or is it possible to target with small molecules as well?
So right now there are at least 2 agonists. Pfizer has it in trials right now, so that's a biologic. I have not seen any small molecules on it, so I don't know.
Thank you.
Very nice talk. I have a question on the final results that you showed about the 38 inhibitor combined with OX40. And so you showed that macrophages and CD4 positive T cells were involved. What about dendritic cells and CD8 positive T cell effectors?
Yeah, so I skipped past it because I saw my timer going off. So if we deplete CD8 cells with the OX40 agonist and the P38 combined, it's just as effective. There's clearly no antigens for CD8s to engage in these models, which is why we put the experimental in. Your second question about dendritic cells, we've used some knockout animals, and we do see a small effect with the dendritic cells, and we also know we've done Zia screen tracking for antigen trafficking, and there's definitely an increase, it doesn't make sense though, in DC1s in the lymph nodes when we put the inhibitor on. Given the CD4 dependency, the easiest answer is it should be DC2s, but we know it's not that perfect separation. So DCs are probably in play. We don't think they're the major driver, though. We really do think the macrophages are the major driver.
Thank you.
One last question online from Doug Yee, the $1 million question. Can you model hormone receptor positive metastatic cancer in your system?
No. But if he knows how, please let me know. We would love to do that experiment.
Many people would love those models. Great. Thank you very much, Dr. Stewart.